In previous podcasts, we spent a lot of time talking about the rise of certain drugs like Ozempic and the quick impact it's had on benefit plans and what insurers have done to kind of mitigate the risk of some of these drugs, like in the diabetes area. But what we haven't spent enough time on, which is why we brought a special guest in today, is to talk about a rise of a lot of specialty drugs and rare disease drugs that are hitting benefit plans like never before. And so Carolyne, we brought in someone special today with a lot of experience in this area to focus specifically around what companies should be thinking about moving their benefit plan forward.
Absolutely. I'm so thrilled to have Gary Walters here. He's seen it all, Rob. He's worked with the carriers. He's been at a reinsurer. He's touched pharma. He's an actuary. He's helped the government, Health Canada. He's on the drugs for rare disease. He's done it all. So he's going to be able to have a really fruitful and well-rounded discussion with us, I think, and really hone in on innovation, where we're headed with high-cost drugs, solutions that are out there for rare disease that are changing families. But the big question we're going to cover off is, who's going to pay? How do we pay for this? How do we plan for the future? So let's bring Gary in and let's get going. Gary, why don't you tell us a little bit about your background and we'll dive in.
Well, I'm an actuary, and I hope you'll forgive me for that. I've been working in the group benefits space basically since I emigrated to Canada in 1987. Initially, the first 12 years or so were with insurers, carriers, including a company that many people won't have heard of, Constellation, then went to Sun Life for a while, did a little bit at MetLife and Canada Life. Then I became a reinsurer, the Canadian Group Reinsurance Operations for a large international reinsurer, Reinsurance Group of America. Did a little bit of consulting then with governments, insurers, pharma companies, and then currently with a large TPA called GroupHealth. Been there 6 years, where I'm the chief actuary for the family of companies.
Nice and well-rounded, Gary, to know the industry inside and out. And in previous podcasts, we spent a lot of time talking about drugs in the news like Ozempic. And it was a quick rise of the popularity of Ozempic, and some people were taking it for kind of what it was, off the shelf reasons, more for weight loss for say then versus type 2 diabetes and A1C levels. But what we haven't spent a lot of time, in our opinion, on as an industry is talking about a lot of these new high cost rare disease drugs that can cost well over $1 million a year, and how we're going to financially pay for this as a country. So we're really thankful you're here today, Gary, to talk a little about, your background and your influence you've had behind the scenes that we think a lot of employers should be aware of. So, we talk about with clients all the time about stop loss insurance or large amount pooling coverage. So why don't we take back a pass, Gary? Talk us a little bit about what is stop loss.
Yeah, let's go back 20 years ago and say what did it look like then and what is stop loss and why did it come about?
Group insurance, or particularly drug insurance, historically was all about relatively cheap drugs. It would be, you needed your amoxicillin or you needed a cholesterol pill or something like that. It was all, 10, 15, 20, expensive one might have been $100. And then the first expensive drug that we sort of heard a lot about was Remicade, which came out, I don't remember exact year, but somewhere 2001, 2002, and it was $25,000+ a year. It fundamentally scared us in the insurance industry because it was completely different to anything we'd done. And very shortly after that came out Fabrazyme, which is a rare disease, but it was $300 and something thousand a person, and that sort of scared even more. And it was at that point that large amount pooling, stop loss became important for the drug side. We'd had it before for sort of covering off accidental death when maybe 4 people died in a car accident and something like that. But on the drug side, that's when it started. So at that point, we started looking at how, as an insurer, could we address this? Because honestly, before that, if there was a really big claim, it got pulled out of experience in setting next year's rates and never really got paid for by anyone, just from the insurer. And it was at that point that a group of us, I was a new reinsurer, and people saying, can you reinsure this? And I said, I don't think I see a way of reinsuring it because of the recurrent nature. And I think that's the important thing to note here. Insurance works well with expensive, unusual, one-off things. It doesn't work so well when you're doing something that's year after year, and particularly group insurance, which is a one-year negotiated rate. If you go into the next year knowing you have a $300,000 claim, it's difficult to decide how you're going to price that.
And I remember this big time in the advisory side, because we would talk about stop loss or large pooling, and it was just a very small percentage of plan costs. Call it was like 4% of a company's healthcare rates or at that time. Well, instantly companies started increasing that attachment level, right? So where maybe the first $5,000 were going to a company's claims experience, also now you're hearing it's going to be $10,000 or it's going to be $15,000. And, the charges that were applied to that stop loss obviously went from 4, drastically, where at some plans, it's well over 20% of a group's healthcare rates are just for this large amount pooling. And so when you talk about sustainability, it wasn't long after that we started seeing a lot of other drugs that came out for, where there was like drugs like, not like Remicade, but then Enbrel, with the great study that these drugs could be used for other therapeutic conditions too, right?
And I think that's one of the peculiarities of this industry, is that you can get a price for a drug, because developing a drug is very expensive. And a lot of drugs they try to develop never get to market. So there's a lot of development costs that a pharma company has to recoup somewhere, and they recoup it off the drugs that are successful. So they go to market with a certain set of indications, a number of people who are going to be on this drug, and you work out a price, and the price can be sort of developed that works well. But then if you get another indication that doubles the number of people, the price stays the same. And we saw that Remicade came, and I can't remember the initial indication, but it's now indicated for 4 or 5 things for about 5-10 times the number of people it was originally designed for. We're seeing this with Soliris at the moment, which is a 600,000, sort of 30, 40, 50 people, and now it's going into other indications that increase it. But the price stays the same. And that's one of the peculiarities here. If you go to Costco to buy a TV and you see I remember the first plasma TV was $20,000, and now the same TV is $500 or less. You can't get plasma TVs. But the next thing, it comes down as you get volume and competition. Most of these drugs for rare diseases have no competition. People don't go out and try and develop 5 different drugs to cover Fabry's disease when there's only 50 people in Canada who are going to get it. So there's not that competition, and we have this where the drug price, once set, stays the same. And that, I think, is one of the problems, is it increases. And then we have so many drugs now that are in that 300,000-400,000. There are a few in the million range, but it's more in that 300,000-400,000. But that's a big impact, and it's expensive, even if you spread it across a lot of people.
So let's look to you, Rob, as an advisor. You mentioned even 20 years ago, you might have seen once in a blue moon, out of your hundreds of clients that you work with, maybe 1 or 2 of them would have this high cost drug or even a rare disease drug. And that would be an interesting renewal discussion, I can imagine. Let's fast forward to today. How often are you seeing high cost and or rare disease drugs on your group plans with your typical small to mid-sized business owner?
Sure. So if you'd say for an organization that might have 50 employees, and you're right, probably 10, 15 years ago, rarely saw a drug. And if we say a specialty drug claim, like anything that was $10,000 a year or more, rarely saw one. It was a handful of situations. Now it's probably every other plan that would have a drug that would be deemed a specialty drug, something that costs $10,000 a year or more in their program. And I think there's 2 things that I'm concerned about as we kind of move forward, Gary, and this kind of leads to the present day a little bit. One, you've seen a change. The adoption of biosimilar medication. So it's, I guess, the simplest form. It's kind of like a generic to a brand name drug, but it's a little different. That's probably the simplest way to describe it. But and happy for your opinion on it too, Gary. But I think the advantage of biosimilars to us doesn't necessarily get rid of a stop loss claim, but it's a lower cost to the insurer in their stop loss pool. And I think that's not a bad thing either, because we want to ensure the sustainability that carriers can manage their stop loss pools because they're responsible for these claims. And maybe that's something else we can talk about, is how these stop loss pools impact insurance companies, because you've been on that side of the fence, one. But we've also seen a real rise in biosimilars. So not necessarily drugs that are $300,000 or $400,000 a year. I know we'll come back to that, but just see the rise of just specialty claims in general.
Yes, similar is cheaper than the reference drug, the original drugs, 60% of the cost. Yeah, and it varies. Sorry, I should have just picked a number, but it varies. But say 60%. So if you've got a $200,000 drug, the buyer is on $1,000. It's still a big cost. If you look at the biosimilar to Remicade, it's well down from $25,000, but it's still, a significant drug, particularly for a small group. And I mean, that's why large amount pooling for insured groups, stop loss for ASO is so important, because you're spreading the cost. But I think the important thing to remember is that in a pool, it doesn't change the overall cost. It's still the same amount of dollars are paid out. You're spreading it around. You're trying not to hit the plan sponsor who is unfortunate enough to get that claim. But it's still the same overall dollars paid out. We're just spreading it. And that's sometimes a misconception, because you as an individual plan sponsor might see it as saving you money, because I've got this high-cost claim. I'm just paying a pooling charge. I don't get that in my experience. But overall, it's the same cost. We're just spreading it.
I've got a really important question that I think I just want to help our listeners be reminded of exactly what, when we're using these words pooling. Let's take that, say, $100,000 drug. And if I have a $10,000, what we're calling stop loss pooling amount on my group insurance plan, what exactly does that mean? How does that work?
So again, and I try and separate large amount pooling from stop loss. Stop loss is when you, as a plan sponsor, are taking responsibility directly for the cost of the claims are actually paid. Insured is when you're paying a premium and the insurer is taking the risk. But what is happening here is you are buying insurance for the amount over $10,000, $15,000, $25,000. So you're paying an amount, and whatever happens, the insurer is taking that risk. So it's moving the risk off you as a plan sponsor to the insurer, and obviously they want to be compensated for that, so they charge you a stop loss premium. In the larger amount pooling, most insurance premiums are impacted by the claims you've made in the previous year. And what the large amount pooling does is it says we won't take into account any amounts over, say, $10,000 in setting your rates next year. But for the privilege or for the switch of the actual risk there, we will charge you a premium to do so. And it's, as Rob said earlier, typically a percentage of the premium, and the higher the stop loss or the pooling level, the smaller the percentages, because the more risk that is kept within the plan sponsor.
Yeah, I've educated clients too to say, it's like, picture it like fire insurance on your home. You're going to pay the deductible, and if your house burns down, you got to pay your deductible and hopefully get your house and your contents back. Large amount pooling kind of works the inverted of that when you're doing your benefit renewals, because first and foremost, how you claim drives your rates. There's no secret sauce. But then large amount pooling, stop loss, or like your only true and out of country coverage, which is usually embedded in that large amount depending on the carrier, is your only true forms of insurance in your healthcare plan, to be honest. And so with those in place, what your risk is. Okay, if it's my stop loss attachment level is $10,000, then the first $10,000 of that person's claims, as an example, for all healthcare, go into your claims experience. Will your rates go up? Yeah, your rates will go up, but then you're protected that if in the event that you get one of these really expensive specialty or rare disease drugs, that's usually once it hits your plan and that individual's with you, it's going to be in your plan every year going forward, right? And I think it kind of leads a little bit knowing that Why don't we talk a bit about the industry's large amount pooling EP3, Gary? We talk about you've been really involved. That's helped the industry at the grassroots, if you want to think about that, to kind of how do we solve this problem as an industry and create fairness with all programs or insurance. Maybe why don't you talk about your background of what it is, one, and what the goal of that organization is?
So when I was a fresh, new reinsurer, some of my smaller clients came to me and said, what can we do about these expensive drugs? And yes, we're worried about the one-off expensive drug, but in a way that's insurance. We can deal with that. It's the recurrent drug, and I think we talked about this earlier. It's the drug that is there that's, could be 25,000 year after year in the case of Remicade, Enbrel, Humira, could be 300,000 a year in case of the others, because that's really difficult. It's not insurance, because I'm going into the contract with the plan sponsor knowing they're going to claim $300,000. So, the inclination is I need to charge them more than $300,000, because I always say the secret of insurance at the end of the day is the premium. Otherwise, it doesn't work for the insurance company. So that was a question was asked, and we sat down. I think we were watching a Euro 2004 soccer game at the time in the bar in Calgary, and we said that we needed to come up with something. The only way we could see of doing it was to pool this across all the insurers. Is that if we put it on all the insurers, then it would average out, because there are small insurers for whom a $300,000 claim in their pool is too much, and they're going to do everything they can to get rid of this claim. And if we could pool it across the industry where every insurer pays their market share of the cost, then there is much less incentive to try and move groups with high amounts from one insurer to another. So that was about 2004, 2012. So it took us a while to sort of get there. We came up with the EP3 and CDIPSI, which started on, I think it was 1st January 2012. And what that does is it looks at those recurrent claims. It doesn't deal with the one-off. It doesn't deal with the first year of a claim, but it's the successive years, and it gets pooled. At the time when we put it together, we had a 500,000, actually I think it was lower than that when we first started, maximum, because that was the highest we could conceive a drug to be. Now that I think is out of date, and the increase has not happened, still limits at 500. And we said, well, we don't want to get caught up in your Lipitor recurrent claim, so it was set at a threshold that went into the pool. But the idea is then that, think of it this way, it's all about risk. The first level is taken by the plan sponsor. The insurer may be doing it just in the year, but over time, the amount up to, we'll pick a 10,000 for the moment just to make it easier. The first 10,000 is going to get reflected in your rates, or if it's ASO, you're going to pay for that claim. The bit between 10,000 and the industry pool is the insurer's risk. So they take the risk of the amount between 10 and, it's a little bit complicated, but basically 32,500 is the insurer's risk. Amounts over 32,500 are pooled between 32,500 and 500,000. 85% of that cost is pooled in the industry. So there is 15 that still comes back to the insurer. But just think of it as sort of layer cake as to who takes that risk. And that's what this is about. So CDIPSI was put in recognizing this was a long-term problem. We put it in and we said, well, we think this can work for a period of time while we come up with a better solution for what's going on. Well, it's now in its 13th year, and the better solution is not yet here. And it is, there's more and more going through it. I mean, it still works. If I was to redesign it, lead the committee again, I think I'd do it slightly differently. But the basic concept, I think, is fairly sound. And while these drugs are the risk of the private payers, so ultimately the plan sponsors, because we know even if insurers are pooling and insurers are sharing between them, at the end of the day, the money comes from the plan sponsor.
I'm just going to jump in to say, Rob, I just can't believe that we're talking to one of the founding godfathers of CDIPSI, otherwise known as the Canadian Drug Insurance Pooling Corporation. I don't remember who won that soccer game that year, but I remember when that came into the industry. And you're right, Gary, there's a lot of elements that have working really well today. It does have an impact to the private insurance side. But there's a big question to be asked. When these large claims happen, these expensive drugs happen, there's really four ways to pay for it. Someone has to pay. So we've just talked about the private side. Let's talk about some of the others of who has to pay if they don't have private insurance.
The way I look at this is a claimant has a condition, disease, problem, however you put it. And when there is no treatment, they have to live with it, and they're paying for it through their daily existence. When a drug comes along that can make a difference, Trikafta is, I think, a poster child here. It fundamentally changes the way somebody with CF can live. How is that paid for? It can be paid for by private. It can be paid for by government. There can be a contribution from the pharma company. It can be paid for out of pocket. Or at the end of the day, the patient, claimant, whoever we think of them, pays for it through their health. Because this is now a health condition I'm living with that I don't need to live with. So if I have cystic fibrosis and I can't Trikafta, I am suffering and I am paying for it for something that needs not be what it is. And we need to remember that at the end of the day, Canada as a whole, whether it's government, people, whatever it is, who have to cover the cost of this, whether it's an individual or not. So it's a risk transfer thing. Is it the individual who's got the risk through their health, or do we change that risk and move it into government or private payers or something?
And this is a good kind of lead in. And I have a client who's on Trikafta. And to give the audience an example, it's $100,000 plus per year, every year. And first and foremost, we're coming back to the large amount pooling corporation that we were mentioning. Initially, as advisors, we were open to the idea because we were excited that it could create stability, that we should still be able to maybe, if one insurance company wasn't working for that client, even if they had a large reoccurring drug, we could change carriers. Well, proof in the pudding that we can't, to be honest. It's sometimes I feel that clients might be stuck with their insurance company in the event of these large claims. And I look at some of these large drugs that are coming down the pipe that, it prohibits companies from making insurance company changes if they have event of one of these large drugs. So you touched on some ideas. If you had to sit here today and kind of look at version kind of 2.0 of CDIPSI, what do you think it would look like in your eyes if you could make some simple changes? If you could minimize the pain points for Canadians with making 2.0, what would it look like in your eyes?
So I think 2 points. Before I answer that, I'm going to go back on one other thing. Yes, CDIPSI didn't make moving insurers as easy as we had hoped it would. I think it's still worth noting, though, that your client is still gaining from pooling, and it could be a lot worse because under the EP3 rules, the amount over the 10,000, whatever their pooling is not allowed to go into affect their individual pooling charge. So there is a gain there. We don't have the degree of ease of moving carriers that we'd wished. And I think that is primarily because even on a $300,000 claim, the insurer has got that bid between 10 and 32,500 plus 15% of the rest. And so that can easily become $70,000, $80,000 that's going to affect somebody's pool and they're charging you, whatever it is, 10% of premium, which is, I'm taking on this group, I'm going to get a pooling premium of $30,000, just picking a number, but I'm going to pay out $80,000. It doesn't look like a really good deal from the insurance company point of view. So if I was going to do things a little differently, I would get rid of the 15% that stays with the insurer and have pool, the CDIPSI, the industry pool, take the full 100% of the amount over 32.5. And at that point, the amount that an insurer is taking on maxes out at that 22,500. The moment that plus 15%, and if it goes over 500,000, they have everything there. So I think that's the main thing. I would also increase the maximum, the 500,000, because I think these days we have to. So why did we put the 15% in the first place? And that was at the time the sort of sense that it would encourage insurers to make sure that they adjudicate claims carefully, and they don't just say, okay, it's not my risk, I'll just pay the claim. I think that's not really the case, because it's not like, well, we'll put you on aspirin instead of Trikafta. I mean, you're either on Trikafta or you're not. There's no choice here. Yes, all right, we need to make sure you do have cystic fibrosis, but you're not going on to these expensive drugs that often have, there's a risk-reward on some of these drugs. There's usually a risk of adverse reactions and that sort of thing. People aren't going on these drugs just for fun because somebody else is paying for them. So I think that the biggest change I would make. And would it make it super easy to move carriers? No. But, if a carrier is limited to 22,500, it's a different calculus at their point of view rather than the risk of 90,000.
Great point.
Yeah. So I'm going to take the conversation in a little bit different direction, because I think there's a few things I want to recognize. Number one, the positives of all of this difficult conversation we're having, it has to do with cost, but the positive out there is the innovation, the access to care, what the drug companies are doing. And Gary, you said it. There's a lot of people that might paint pharma as sort of the evil company that makes a lot of profit, but they deserve it. Like, they're innovating, and it's not all truly profit for every single dollar, right? You mentioned there's a lot of drug trials that take place. I'm going to make this number up because I don't have any stats on it, but for every 100 drug trials that take place, there's probably the majority of them that fail. And the cost that's gone into that is enormous. So it's the successful ones that drive innovation, motivate innovation, and actually change people's lives at the end of the day. Let's talk about this and really bring it forward to today's problem and pain point, whether you've got insurance or not.
I think it's an extremely important point. Without big pharma, we wouldn't have these drugs. We wouldn't be having this conversation, but there's a lot of people in this country, a lot of your employees or their dependents, who would be very much sicker and less able to live their lives than they do today. So pharma does a lot of good. Now, we can all argue about how much profit should they make, but they do take significant risks, you said. And you said you think the majority of drug trials don't go anywhere. I think the vast majority. Again, I don't know the numbers, but I think it's somewhere in the 10% or maybe less that actually sort of make it to market. But it's an unusual economic situation, because this isn't true market economics, because there's not competition. So, somebody brings out a drug, it may be the only one, and particularly for drugs for rare diseases. Yeah, if you're doing an antibiotic, there's opportunity to have hundreds of antibiotics out there and compete, and and then we can say, well, if we put all the purchasing power of Canada together, we can get cheaper prices, which is true when there is competition.
And there's frequency there too, right? There's everybody in this room. would have needed antibiotics at one point in their lives, right? So there's the cost is according to the volume, right? So let's talk more.
What we have to remember is when there is only one drug to treat a condition, if the pharma company decides not to launch it in Canada, it's not that they can go off and get another drug. So we can negotiate and everything we want out of the pharma companies, but we need to recognize that our negotiation leverage is limited. They obviously want the drugs out there because they're not going to get any money, if it's not launched. But Canada is, whatever it is, 0.5% of the world's population, maybe 2% of the world's drug market. You have to be careful. I mean, people talk about New Zealand. Drugs are a lot cheaper in New Zealand. They've really beaten down the prices. But as I understand it, there's an awful lot of drugs that never get launched in New Zealand. So in New Zealand, your drugs are cheap for the ones you can get. And so there's this balancing act. And this is why I personally believe we have to start working with pharma rather than treating them as the enemy. Because if we treat them as the enemy, why are they going to help us when they don't need to? Most of these drugs, if they only ever launch them in the US, they'd make all the money they needed. Yes, you go to Switzerland and a few places in Europe, and that's good as well. Do they need Canada? The answer is no, they don't need Canada. As I say, we're 2% of the pharma market. If they launch, if we beat them down so much in price that they choose not to launch, then who suffers? It's not the pharma companies. It's our members, it's Canadians, it's our friends, it's our kids. And having talked to people in pharma, I think they're open to constructive discussion because they really do want their drugs. There are a lot of people in pharma who really get a kick out of helping people.
Yeah, we have to play in their sandbox. I think that's a big thing. And I think if we've learned anything, especially like owning businesses, is that cheaper doesn't mean better. And speaking of like cheaper doesn't mean better, is like this is a good time to start talking about a lot of these rare disease drugs that we've just kind of been touching on, but maybe give people an idea when you start talking about rare disease drugs, Gary. We know it's a very small percentage of the population that might need one of these drugs, but you brought up Trikafta for cystic fibrosis, which we talked $300,000 a year every year for somebody's life, and is life-changing for these individuals. So talk to us a little bit about your concerns as we fast forward now into the future, and then around rare disease drugs in your eyes, and what are some of the concerns that you have as someone who's been a guru in the drug landscape for 35 years?
Drugs for rare diseases, by their nature, are going to be expensive because spreading the cost, the development cost, over a smaller number of people is going to push the price up. And there's lots of arguments how much it should push up, but I think the fact they're going to be more expensive is clear. We have not in Canada defined what a rare disease is. I sit on an advisory group with Health Canada, and it's something that has been studiously ignored at this point or chosen not to. The Europeans have one definition. The Americans have another definition. We have chosen not to define. It's sort of one of those things that a lot of the time we know it when we see it, but whenever you draw a line in the sand, somebody's going to be on the wrong side of the line, and you know that any line in the sand is going to be a lot of pressure on it. There are, and I've heard 10,000 rare diseases of which we have drugs for a couple of hundred. So the universe of what can happen is close to infinite here. I've also heard that 1 in 100 Canadians or something has a rare disease. So the numbers multiply very quickly. And I think that's what worries me the most, is can we, as Canada as a big thing, whoever the people are in there, can we afford to keep up with helping those who have these often terrible conditions? And probably sounding a little depressing here. there's part of me that does worry about whether it's government, whether it's private, whoever it is, can we cover that? There's sickle cell disease is a disease that affects, and I think it's about 6,500 Canadians, and they've come up with a treatment for it. It's 2 million, one of the treatments, the other's 3 million. Wow. They believe it's curative because it's a genetic, but multiply it up and you're at a $20 billion cost.
Wow. So this drug alone, like when I think about now, Gary, you'll know the numbers better than I. So even today, and I think you're right, we need everyone at the table to figure this out. We need insurance, we need government, we need pharma, we need everyone. Government alone has put aside a budget in today's world for drugs for rare disease. What does that look like, and what would it do for this condition alone?
So just clarify, this is a genetic therapy.
Right. Okay.
I think the two bleed into each other, or will be bleeding into each other. The government's put aside $500 million a year, $500 million a year, which, to be polite, is a drop in the bucket. Yeah, I've seen numbers saying that through private insurers, they're paying out over $600 million a year, and those numbers are several years out of date. I've seen numbers of total encounter about $3 billion, because a lot of these at the moment have been cancer drugs, so they're in hospitals, they fall onto the provincial plans. But as an aside here, one of the things, a lot of the new drugs for cancer are now oral, not injection, which means they're out of the hospital, which means they move from provincial plans onto private plans. It's just an aside, not a good aside, but that's an aside. But my concern is that there's going to be a lot of these, and the heartbreaking stories of people who can't get it, or the uplifting stories of what it does to the people who can get it, means that there's going to be, rightly so, a lot of pressure to pay for these. It's just going to be very expensive. That one, the sickle cell, okay, we think it's a one-off treatment, doesn't know yet, but these genetic therapies generally are, because they're changing your DNA at some level. So, but still, one of these comes out every year. It's a $20 billion cost every year. The $500 million from the government is a drop in the bucket. They need to use that. They're assuming that the provinces will come to the table with some of it. I am presuming they are presuming that private will come to the table. But in the group, the implementation advisory group that I sit on, we're looking at how to deliver this stuff. We're designing the car, not looking at how to pay for it. That is something that still needs to be addressed. And that's my worry, is that we're going to come up with a great system. I don't know who's going to pay for it, because it's going to grow.
I think it's clear that, again, we need everyone at the table. We're talking about drugs for rare disease, but I think, as you just said, Gary, there's drugs for cancer. This is not rare, right? There's a lot of people that get cancer. There's a lot of people that have other drugs. And when I think about, there's different experiments, if I call it that, or pilot projects happening across Canada by province in the world of how people deal with this. So I'm encouraged to try to take, I'm always the glass half full gal. I'm always encouraged to think about how might we learn from provinces or countries in designing a system whereby we look at out of pocket and we consider what is the right amount out of pocket based on income, or what are the right measuring sticks, right? There's a lot of talk on pharmacare on this right now too. So I'll share an example, one that people might relate to a little bit more. I've been using recently because I've been having chats with my friends and family about all of this. I have a friend of mine who has 2 daughters in university. One of them is about to graduate. Both of them, unfortunately, have Crohn's disease. They currently have a cost differential because they have different drugs they need and different treatments. One of them's about $51,000 a year. The other is $21,000 a year. Let's take the $51,000 a year. She's about to graduate. She's on Dad's plan, who has 100% coverage, which is great. But now what's her number one worry or thought as she graduates? It's not, where might I work? What's the culture? What's the environment? How do I get there? Do I commute? Do I not commute? It's, do you think I could look at their benefits booklet to see if they have 80% or 100%? That's her number one thought, and her family and the stress that they're all going through. And then considering, should she live at home or not at home? Because if she's not living at home, she has a better chance of getting maybe some provincial funding. All of these stresses and questions, I just can't help but share that as a real life example that not only for this condition, but there's other day-to-day high-cost drugs where, let's face it, 20% out of pocket is not manageable. So let's dive into that. And maybe, I think my question for you, Gary, though, is I want to keep it, what can we learn from the provinces and the systems that are out there that are something we can look towards developing to the future and innovate and create something that's long-term sustainable with all the players at the table to help it make it work?
So firstly, a quick bit of advice to your friend.
Yes.
There is a chance, depending on what the drug is, that if she ends up with a 20% co-insurance, the drug manufacturer may support that. So it's worth going down that route, but they may not. So come back to something that I have been espousing for a number of years, which is, I think we put in the 80% co-insurance as a common private plan approach many years ago when people were buying drugs that were $50 and $100 to encourage people to make sure that when they bought the drug, it made sense and they took it and that sort of thing. They had a financial involvement.
They had skin in the game, that if they need it or if they're going for massage, that, hey, you're going to pay part of that cost, right? Times have changed.
I don't think that works for things now. And I really believe that private plans should put an out-of-pocket maximum in. What should that be? It depends a little bit on your workforce. If you're a legal firm, maybe you can put in $1,000 or $2,000 or something. If it's one where they're much lower paid, maybe it has to go lower. So I do believe private plans should consider the out-of-pocket maximum. I do get pushback. Well, sometimes drug companies will pay anyhow, so we don't want to, save them money. And I take that point. But going back to what can we learn, we have in Canada 3, 4, 5, 8 different approaches to drug plans. And we can pick 3 probably to sort of typify what goes on a bit. We can pick BC, we can pick Ontario, we can pick Quebec. And I'm not trying to ignore the other provinces, but there's a lot that look like Ontario to some degree or another. If we look at BC, there is an out-of-pocket maximum. You pay a maximum amount under the BC Fair Pharmacare program that depends on your family income. The maximum used to be $10,000. I think it may have gone up a little bit. But it's still, to be hit by the $10,000, you've got to have pretty good family income. And the government covers the rest. Now, it's a restricted number of drugs. It's 5,000-6,000 drugs. But so private plans pay that deductible. The government pays the amount in excess. You go to Quebec, on the other hand, it's all private coverage, but you have to do it. Legally, you have to take it, and you have to do it. And just going back on the CDIPSI thing, one of the challenges we had when we developed that was we had no way to compel it. Whereas in Quebec, there's a QDIPSI, the Quebec Drug Insurance Pooling Corporation. Everybody has to legally be part of it, and that does change the way you work things. But in Quebec, there is an out-of-pocket maximum for an individual, and private payers who have to cover all these drugs, and the number in Quebec is much higher than it is in BC. It's still not the whole universe. There is a pooling there. Again, it's amongst all the private payers, and that varies on the size of the plan. So CDIPSI kicks in at 32,500 across the board. You can negotiate your own EP3 level. But in Quebec, if you are under, I should know these numbers, under 20 or 25 lives, it's an $8,000 maximum, and then once you get to 6,000, I think it's unlimited. If we can learn that, if we come to Ontario, you're on your own, i.e. it's private coverage, but there are certain ways where they will cover through Trillium a certain amount when you hit a certain out of pocket. So I think there's an amalgam of these that we can put together, take the best, remove some of the problems, where we actually look at a governmental sort of stop-loss layer, pooling layer. So we go back to the risk taken, by the individual, by the plan sponsor, by the insurer, by the industry, and then a top layer that maybe is taken by government. And that can come together through, some sort of amalgam of Quebec and the BC. In some ways that then takes on more cost plans, because if you go to the Quebec model, it is a bigger universe of drugs that you have to cover. And so, it's always this balance between what is good for your employees, for their health, and the benefits you get from them coming to work. They're not having to worry about their kid or themselves, that sort of thing, versus the cost. And if you've got somebody who's got a kid who's got cystic fibrosis, that's a one-parent full-time without Trikafta. With Trikafta, I believe that it sort of frees up people.
Well, and I guess, a couple things that come to mind is the advantage of a private benefits plan is that if I have my drug card, and it's an easy navigation to get coverage for that. When somebody doesn't have that private coverage right now, as you break down, like, coverage varies by province, because healthcare is managed by the province. It's not managed federally. And therefore, depending where you live, and we've talked about this in previous podcasts, is that, like, to navigate it on your own when you're already dealing with the stress of somebody who's in a medical situation, that we just talked about those couple situations there, it's a challenge. And, like, to try and navigate, healthcare is this giant complex onion with so many layers in there. And maybe I got a question for you, Gary, is that we've recently in this country announced a pharmacare program that initially is going to cover contraceptive for those that do not have coverage, and diabetes medication as well. And my personal take is I feel like we missed the boat. I think, and I know there was cost limitations there, which is fine, of what you could cover and not cover, but having this discussion, around rare disease drugs and specialty drugs is something, as an organization, Benefits Alliance, we took to heart when we were part of. We wrote letters to Parliament and Prime Minister Trudeau and Ministry of Health, talking about how we feel or what should be potentially covered under a national pharma program. We weren't against it. We're saying some of these issues that we see coming down the pipe, like you do. So if you had your own crystal ball, like, what would you like to see in that example to summarize under a national pharma program and minimize that risk? Because I think there is an opportunity where private plans could actually, and employees specifically, really benefit. If a lot of these large cost medications weren't responsible under a private benefit plan, companies could do so much more for their staff.
So I want to correct you on one thing there.
Go for it.
The National Pharmacare, as is the bill as it is sitting in front of the House of Commons at the moment, doesn't cover contraceptives for people who don't have coverage.
It would be general.
It covers contraceptives for everyone.
Appreciate it. Thank you.
So what this will do is it will remove contraceptives and some diabetes medications from the private plan sphere. It will potentially save private plans, and it's my initial look at our block is 2-3% maybe. Right. So I'm going to step back and talk now a little bit as a Canadian rather than necessarily as somebody who's involved in private plans. Even the most pessimistic surveys suggest that 75% of Canadians can cover their costs. It's 22, I think it's 22%, was a survey recently quoted by Jagmeet Singh, I think, that said 22% of people have had to make decisions about what drugs they take because of financial. So that implies that 4 out of 5, 3 out of 4, however you take it, have adequate coverage currently. And one suspects that the remaining people, a lot of those have some coverage, but maybe they're caught by the 80% or something like that and have had to make a decision. So we, federal government, Canada, taxpayers, we're going to invest in covering 3/4 of the population who already have coverage. As a plan sponsor, you may think that's good. I'm uploading my costs to government. At the end of the day, we all pay for it. The government, yeah. I was going to say taxes have to exceed their expenditure, but that's actually not true, is it? But, they're going to have to get the revenue from somewhere. So why are we spending, and I don't know how much this is going to cost, but I've seen a number of about $1.2 billion, which we only need $300 million to cover people at a maximum who don't currently have coverage. That's $900 million that could have gone on to the $500 million they've already put out for drugs for rare diseases and expanded the coverage, and it starts to get meaning. $500 million, honestly, they called it a drop in the bucket. If we could do that, and then we go through something like the Quebec or BC type people have their private coverage, they do their drug card, it gets pooled at an industry level, and then the government takes pooling at the top, then nobody actually needs to interact with the government. It's still a single luxury, and things happen behind the scenes. And just one last thing, you say it's difficult for people to navigate. Believe me, insurance companies have a whole batch of people who are trying to keep up to date with all the differences in all the provinces. It's not a straightforward thing. Even when you're an insurance company and you have all the people trying to think it through and to design, anybody's got a plan that covers across Canada, do you philosophically try and give people so they all come to the same level of coverage, which means in some provinces you're paying an enormous amount and others you're paying much less? There's a whole difficult thing.
Yeah. I think as we wind this conversation, I'm going to say there's a lot that's taken place in the last while that has occurred. I'll say the National Dental Program. There's now what's on the table or proposed for pharmacare. What would you say, I'm going to ask this to both of you, Gary and to Rob, in turn, what should employers think about if they're looking at putting in a plan for the first time, if they don't have one today, and they're designing it, or if you're looking at adjustments to your plan? What are some important, I'm going to say philosophical questions, value-based questions you should ask, but also practical design and trying to build something that's sustainable, knowing that there's all of this sort of noise happening. So maybe I'll start. Yeah, go ahead, Gary.
I got to make a point and then answer your question. We have a choice in Canada as to whether we want to try and go to this single-payer national pharmacare, whatever it is. So we cover everybody exactly the same. And based on our experience with pharmacare in BC or whatever, it doesn't cover everything. So I think a lot of people think national pharmacare just means I'll get whatever I want for no cost. It won't be that. So that's one choice. The other choice is to try and fill the gaps. And from a financial point of view, filling the gaps is a lot less. It leaves a burden on employers. Doesn't change the cost. We've got to pay for it. And maybe I'm a cynic, but to think that government's going to do it more efficiently than the private doesn't sort of resonate with me. So, this is our choice. The National Dental Care Program is designed to try and be a fill the gaps. The National Pharmacare, as it has been announced at this point, is an across the board, everybody gets the same. We have a choice to make as a society, and we need to sort of work out where we're going. I think what we need to think about, so the National Dental Care Program, I've had a lot of people say, so how should I be changing my plan? It is designed in a way to fill the gaps. And it's actually really difficult to change your plan to sort of upload the cost of dental to the government because it's all based around family income. And unless you happen to have both partners working for you, you don't know what family income is. Maybe not true. If you've got single people, you probably do. But for most of your employees, you don't know what family income is. And you can't ask. I mean, that's private information. You can't ask that question. So if you try and cut people out and saying, well, if you earn more than, because the cutoff broadly is 70 to 90,000, let's say you say, well, I'm not going to offer dental to anybody who's earning under 40,000. Well, if you've got two spouses earning 40,000, neither of them are getting dental care, and they're not getting anything meaningful through the government. So it's really difficult there to try and upload, which is what they were trying to do. They were trying to make this fill the gaps. So on the dental side, at this point, I don't see that there's a lot people should do. There's also a shortage of dentists signing up for the program, so that's another point. On the drug side, I mean, I think it's a case of wait and see. I don't think you need to do anything specific to your plan. Most plans say we won't cover what the government covers. So if the government covers contraceptives and these drugs for diabetes, your plan won't cover them. You don't need to change that. But the impact is going to be very, as I said, small, 2, 3. Depends what they cover on the diabetes side, and we have test strips and glucose monitors and things, whether it might get up to 5 or 6. But and that experience will flow through as it comes in. We also don't know which provinces are going to be part of this. You said they want to be Alberta. I said no. Quebec, I said, and in a way, it's sort of the predictable political reaction to these things. I think things will change as people start sitting down as the government best for Canadians. But at this impact, what you should do with plan. Drugs for rare disease is something. Now, if you are a smaller player and you're, yes, I should think about that. Because as more of these drugs come along, yes, they get hit by your stop loss, but there is nothing to stop your insurer loss represent your pooled claims closer and closer. If it's insured under CDIP, CEP3 rules, what will survive, what won't, what will the provinces agree to, what won't they? We're not going to have a national program because we're never going to get 10 provinces to agree here. We're just going to have a different postal code lottery.
Yeah. And we can learn a lot based on the decisions people make because, let's face it, as we've said through this whole conversation, we have to understand what we can do to keep innovation happening in an affordable and sustainable way. Yeah. Rob, any final comments you would have as what you're seeing from questions from your clients, your plan sponsors, your plan members? What's on your mind as we wrap this up?
Yeah, well, first, I love, Gary, that the Canadian Drug Insurance Pooling Corporation came to light at a bar over beers and soccer. Some of my best ideas have come over a couple drinks, to say the least. But to hear those points, Gary, first, I agree with you completely on all those points you just made there. I said, innovation's not going away. With studies of the genome and the ability for these big pharma companies to come out with life-changing medication for people that comes at a cost. And, if you've ever had a sick child or family member, it doesn't matter what it costs. Like, what can we do? So knowing that, and I agree with you, I think the national pharma debate is going to go on for years, and how it plays out, we don't know. But innovation's not going away. High cost drugs are not going away. Rising benefit costs are not going away. And so when we sit down with employers of all sizes, whether they're putting a plan in for the first time or they're doing a revamp of their existing program, usually ask a few questions. One, do you feel like your employees should have some skin in the game cost affiliated with, the design of your program? Should they share in some type of the cost? Not necessarily sharing premiums in terms of cost, but you have to take ownership in the plan, maybe where they go to pharmacies or what type of drugs they get. 1. 2, ask that common question. Listen, if an employee needed a very expensive drug one-off, i.e. cancer medication, which might be just needed for a certain period of time. Do you want to cover that? Yes or no? And yes, your costs will go up, right? And then you talk about design. And I think the biggest thing that companies have to realize in terms of modernizing their program, we talk a lot about this in Benefits Alliance, modernizing programs. Are there options out there that other players can possibly cover some cost of this medication? Yes or no? Do they want to go down that road? Do they want to cover these expensive drugs if somebody requires one of these drugs is a common question. And therefore, then we design the plan backwards from there. Gary brought up a good point. The majority of companies in this country self-fund their benefit program, right? And just, they lure admin, whatever your claims are, add your min fee, that's your bill. We've probably had more companies, that mid-sized market, change from self-funding back to fully insured because they've experienced large cost claims. And at the end of the day, that's like stop loss will help you year one. But yeah, you're at the mercy of the insurer that, they, again, coming back to an earlier point, is that they got to make sure their premiums exceed claims, for sustainability long-term for the insurer. So I think, it's important. I've loved today's conversation because I think it's important for people to realize that, you want to be proactive with your benefit program as much as possible instead of reactive. And unfortunately, majority of benefit plans are reactive. After something happens, what do we do now? And this is one of those situations where that you might not have a lot of flexibility, depending if you get one of these rare cost drugs. So Gary, thanks for coming in today and shedding a lot of light on a topic that we know as benefit advisors is extremely important. So appreciate all your knowledge and expertise today.
Yeah.
You're welcome.
Thank you. We've looked at past, present, and looking at hopeful for the future that we can find that solution. And in the meantime, I think just as we concluded here, I think for employers listening to this, don't assume what's going to happen or how to interpret what is happening. Definitely talk to your advisor, get advice on what is something that you need to look at before you make a change on your plan. So thanks, Gary. Thanks, Rob. And we'll see you next time. This has been the Benefits Alliance Voice. If you enjoyed today's episode and learned something, please share it with your network.